On to today's topic and our speaker. The topic today is everything from diagnosis to decisions. So, our goal for today is really to help give you the information and the tools necessary to be able to make informed decisions about your care with your doctor and so that you can feel confident doing it. We have an amazing speaker, Dr. Dale Bixby. Dr. Bixby is a clinical professor and specializes in the areas of myeloid and lymphoid leukemias, as well as MDS and bone marrow failure disorders. Dr. Bixby currently serves as the section chief of the Acute Leukemia program. He is also a clinical investigator in hematologic malignancies. So I am excited to have him here with us today. And with that, I'm going to go ahead and turn the presentation time over to him.
Can everybody hear me okay?
Yes.
Okay. Um, as mentioned, I'm a clinical professor at the University of Michigan, and my clinical interest is in the care and management of patients with acute leukemias, other myeloid malignancies, and bone marrow failure disorders. And it's my honor today to discuss with you for the next half hour some thoughts that I have on your diagnosis of acute myeloid leukemia or a loved one's diagnosis, and things that you should think about and discuss with your primary hematologist regarding your diagnosis and management of your disease. And as mentioned, I'd be happy to stick around at the end of the presentation to be able to take questions regarding our presentation. I don't have any disclosures financially that are relevant to today's discussion. A quick objectives. I'll spend just a few minutes talking about the epidemiology of acute leukemias. We'll define what an acute leukemia is, as opposed to other subtypes of blood disorders that you may have heard about. We'll quickly move through how your diagnosis is going to be established and how a provider looks to establish a diagnosis of acute myeloid leukemia. Increasingly, we're using genetic testing as a part of diagnosis and management of acute myeloid leukemia. And I'll go over a few terms and important tests that I think should be a part of a patient's care and management and how they may influence your initial therapy, which we term induction chemotherapy, as well as your consolidation or additional therapy that would be given to prolong your remission or improve cure rates. With that, we'll go ahead and get started. So a quick word on epidemiology. Acute myeloid leukemia is the second most common leukemia diagnosed in the United States. There are about 22,000 patients diagnosed each year. The median age is around 68, and the graphic on the left does give some admittedly sobering statistics. The median survival rate for 5 years is around 33%. Although if you had seen this slide around 5 years ago, that median survival would be around 25%. So we are making good strides in improving clinical outcomes and therapies for our patients. There are obviously a lot of factors that go into survival in acute myeloid leukemia. So I don't want everyone to take away that the median survival for everybody with this disease is the 30% number that I quoted. There's increasing options for care and management of patients, and this number can vary widely based upon individual circumstances. I will note on the right-hand side of this slide that there are factors that influence what therapies are available to patients, and some of those factors include a patient's age. And you can see that the diagnosis becomes increasingly likely as one ages, with the majority of patients diagnosed with AML being in their fifth, sixth, or seventh decade of life. So a quick word on the diagnosis and how we use the definition of acute myeloid leukemia. So an acute leukemia is actually a cancer of the blood, or sometimes we'll say of the bone marrow. And acute leukemias are actually an accumulation of cancer cells that arise from immature blood cells that we term blasts. So the word acute in acute leukemia doesn't mean time. It doesn't mean that it came on all of a sudden. It means specifically a cancer of blasts, as opposed to chronic leukemias, which are cancers that lead to the accumulation of mature white blood cells. And we'll see a demographic or a slide on this in just a few minutes. There are two types of acute leukemias. acute myeloid leukemia, or AML, which is the accumulation of immature myeloid blasts. And we'll define in just a few minutes how we establish the myeloid nature of those blasts, as well as acute lymphoblastic leukemia, or ALL, again, using some additional information we'll go over in just a few slides. This is a schema that we show many of our medical students. It talks about how blood is made in your bone marrow. And I kind of think of blood making like a car assembly line. Those cars start out at an immature stage of development and go through a series of mature steps before they leave the bone marrow and enter the peripheral blood. In this case, blasts are that immature starting point. And over time, those blasts should grow up and mature and become either infection-fighting white blood cells, oxygen-carrying red blood cells, or platelets that help clot your blood. In this case, in the case of acute leukemias, some of those early steps are the cells that became cancerous. So you can see on the upper left-hand side, a type of cell called a myeloid blast has become cancerous. And when that happens, we use the term acute myeloid leukemia. And on the right upper side, when an early lymphoblast becomes cancerous, we use the term acute lymphoblastic leukemia. Chronic leukemia, shown at the bottom, are cancers that ultimately drive or give rise to more mature white blood cells. To establish a diagnosis of acute myeloid leukemia, we, the physicians, need to identify approximately 20% or more of these myeloid blasts, either in a patient's peripheral blood or bone marrow. So the question becomes, how do we identify these myeloid blasts, and what tests do we do to establish their presence? And so oftentimes your physician may ask you to undergo a bone marrow aspiration or biopsy. And I've just shown a cartoon representation of this procedure. Typical samples that one needs to obtain, and I would say needs to obtain, is a liquid sample of the bone marrow. We call that the aspirate specimen. They'll take a little fragment of the bone called the core biopsy, and they'll take additional liquid samples from the liquid part of the bone marrow for genetic testing, including a test that we call cytogenetics, and a last genetic test that's often termed a myeloid next generation sequencing test. Again, what we're trying to establish is the presence of an increased blast population. And as I mentioned on the prior slide, if you have 20% or more blasts in either the blood or the bone marrow, that really establishes the diagnosis of acute leukemia. And in those cases, sometimes we can obviate the need for a bone marrow aspiration biopsy because we can actually look for those blasts in your peripheral blood, and you may not need a bone marrow aspiration and biopsy to establish that diagnosis. But these same tests should be sent on the peripheral blood if not obtaining them on a bone marrow sample. And this just gives a physical representation of the samples that we often acquire. On the upper left is the bone fragment that we often obtain through a bone marrow aspiration and biopsy. And on the right upper part of the slide is what the pathologist will see when they're looking under the microscope at that core biopsy and assessing for the presence of those increased blasts. On the bottom left is a technician obtaining a bone marrow aspirate. The aspirate actually is red, like blood. But under the microscope, the cells that constitute your bone marrow look different than the cells in your peripheral blood. And again, what the physician team is looking for is the presence of that increased blast population. So step one in establishing the diagnosis of acute myeloid leukemia is identifying 20% or more blasts. Step two is proving that those blasts were trying to become myeloid blood-making cells. Now, in that cartoon representation I gave earlier, the myeloid blood-making cells, if we think about that assembly line, are the cells that are trying to become infection-fighting white blood cells or oxygen-carrying red blood cells or platelets, but they're just at an immature step or stage of development. We can actually test for their potential, what they want to become, by looking at proteins on the surface of those cells. And those proteins on the surface of those blasts help us identify what those cells were trying to grow up and become before they got stuck at that immature stage of development because of the cancer development. And we often use a test called flow cytometry to assess for those proteins and to establish whether that blast is a myeloid blast or a lymphoid blast, thus making the diagnosis of AML versus ALL. But I also mentioned additional genetic tests that would often be done on those leukemia cells. And why do we do them and what do they add? So a few words on what genetic tests do for patients with acute leukemias. There are some types that the genetic tests that we use actually are diagnostic for AML itself, or specifically a subtype of AML. There are occasions when the genetic test results and indicate that the patient may have inherited a mistake or a disorder that predisposes them to the development of AML. Some of the genetic changes that we obtain or get are prognostic. They help us understand how well a patient might do with their diagnosis, and they can be predictive. In other words, they can help us sometimes identify what therapies are best for a patient based upon the presence or absence of specific genetic mutations. And then finally, in some circumstances, certain mutations can be used to monitor for a response to therapy. If the mutation was present, there are sometimes we have tests that can test to see if that mutation is persistent after therapy is given to see how much leukemia might be left over. A quick word on inheritance. More than 98% of the time, the genetic test results that we get in a patient with acute myeloid leukemia are what we term somatic changes. Somatic means that you were not born with these mutations and cannot pass them along. They are spontaneous mutations just in the leukemia cells. So in my simple analogy on the screen on the right-hand side, the tree has one red leaf indicating that that mutation was just in that single cell and not inherited in the entire tree. But as mentioned, about 2% of the time in the genetic testing that's performed at the time of your diagnosis, we do identify mutation that you did inherit from either your mother or father, and theoretically you could pass it along. And those constitutional genetic changes are important sometimes both for the care of the patient, but also to discuss with your physician team about how others in your family should be tested for the presence of that inheritance and what follow-up they should have based upon the presence or absence of that inherited constitutional change. A very common question asked to me by my patients is, what type of AML do I have? And I don't intend anybody on this talk to memorize this list. The diagnostic classification system that we use currently for AML is called the World Health Organization, or WHO, classification system. And there are 22 subtypes of AML, 11 of which are diagnosed based upon specific genetic changes that are seen inside of the leukemia cells. But in reality, there are hundreds of different types of genetic changes that can be identified in a patient with AML. And rather than worrying about the specific subtype of AML that you have based upon the WHO classification system, I think it's important to speak to your physician about the genetic changes that they did find in your leukemia. And we'll talk in a few minutes about how those genetic changes can break patients into three risk groups, including favorable risk, intermediate risk, and adverse risk, and how those genetic changes should influence both the initial therapy for your leukemia and your long-term therapy for your disease. So why are there different subtypes? Well, the different subtypes and specifically the different genetic changes, as I mentioned previously, can be prognostic. They can also influence your initial therapy. That initial treatment we term induction chemotherapy may be different based upon what genetic changes were seen inside of the leukemia cells. And as mentioned previously, the additional therapy that one needs to receive to improve clinical outcomes, called consolidation, may also be different based upon what genetic changes were present at that initial diagnostic time. I'd like to speak for just a few minutes on a general scheme for the treatment of AML. Obviously, each patient is unique, and there are a lot of different ways, as we will see in just a few minutes, about how we approach the treatment for AML. But I thought it would be important to go over just a few definitions and bigger picture items for how we approach the treatment and management of a patient with newly diagnosed AML. So once the diagnosis of AML is established, as I mentioned previously, your physician should meet with you and discuss your initial or induction chemotherapy. And we'll talk about what induction chemotherapy looks like in general in just a few minutes. After that initial induction chemotherapy, your team will ask you to repeat a bone marrow aspiration and biopsy. And the purpose of that biopsy is to assess your response to that initial induction chemotherapy. After that response assessment, a team member will meet with you to discuss the results of that disease assessment, bone marrow aspiration, and biopsy, as well as the genetic changes that were seen at the time of diagnosis. And then, as mentioned, oftentimes your provider will break your disease down into 3 risk groups, either good or intermediate risk disease, or what some patients will refer to as poor risk or adverse risk disease. And there are different types of consolidation given for these different risk groups. For many patients with good or intermediate risk disease, you and your team will talk about additional consolidative chemotherapy alone. And for patients with adverse risk findings, and we'll define in just a few minutes what adverse risk findings we're going to talk about or what your physician will talk about, those patients may be considered for a bone marrow transplant or a stem cell transplant. So for around 50 years, the initial chemotherapy was, and for many patients still is, a regimen known as 3+7. It's called 3+7 because patients receive a rusty red colored drug called idarubicin or daunorubicin, plus a clear drug that will hang on a pump next to the patient's bed that drips in all day and all night for 7 days called cytarabine. And so patients concurrently receive the 3 days of daunorubicin and 7 days of cytarabine, thus termed 3+7. And this was originally demonstrated to be effective for remission induction by Jay Yates and James Holland, pictured up on the left, who are traditionally thought of as the godfathers of therapy for patients with acute myeloid leukemia. And as mentioned, they published the initial experience with these 2 medications back in 1973. And still today, for many patients, 3+7 should be the standard of care. But 3+7 is a very intensive induction chemotherapy regimen, and it's not right for everybody. And so over time, we've taken into account a patient's fitness and the genetic changes that we see inside of the leukemia cells to determine if alternative induction strategies might be right for them. Some of the features that a patient may have that says that 3+7 might not be the appropriate induction chemotherapy regimen include patients who are older in age, that is, often 75 and above, those with heart failure. An echocardiogram will often be performed to assess heart function before induction chemotherapy is initiated. And what we're looking for is the squeezing of the heart and ensuring that we understand how the heart is functioning before chemotherapy. Individuals with lung disorders like COPD or emphysema may not be the best candidates for standard induction chemotherapy and may need alternative options. Those with chronic kidney disease or advanced liver disease may also not be the best candidates for standard induction chemotherapy. Patients sometimes present with active infections because the immune system is weakened by the diagnosis of acute leukemia. And many times those infections need to be controlled before initiating induction chemotherapy. And there are a number of other features that a physician team will look at on the patient's overall health and wellness to determine the appropriate induction strategy for each individual's case. I know this is an extremely busy slide, and I don't mean it to be overwhelming, but this is the current landscape of the therapy or induction options for patients with AML. And as you can see, it's quite complex. We take into account, again, many of those genetic tests that I mentioned previously. We also assess for patients who may have had pre-existing bone marrow disorders. So some patients with acute leukemias actually had pre-existing bone marrow failure disorders. like myelodysplastic syndrome, or myeloproliferative neoplasms like polycythemia, essential thrombocytosis, or primary myelofibrosis, or even bone marrow failure disorders like aplastic anemia or paroxysmal nocturnal hemoglobinuria. And those diseases can evolve or change into acute myeloid leukemia. And all of those features, together with the patient's age and performance status, allow us to personalize therapeutic options for patients. And so I do think it's critical that each patient sit down and have a discussion with their provider on what features about their case or their condition are the reason for the recommendation for the specific induction chemotherapy recommendation. As I mentioned numerous times previously, there are a number of genetic tests that are run on that initial sample. And some of those genetic tests can take anywhere between 3 days to 3 weeks to return. And not every patient has time for that full panel of genetic testing to return before proceeding with their chemotherapy. And so I think it's important for each patient to feel comfortable asking their care team, in their case, should we wait for the results of that genetic testing before proceeding with induction chemotherapy, or should we proceed with treatment because their health and safety is at risk if we do wait? And there are many options for induction chemotherapy that can be given without a full cadre of results of that genetic testing. So, as mentioned previously, after your initial chemotherapy, after your induction, a bone marrow aspiration biopsy will be performed to assess your response. And again, the disease should be broken into, and you should have discussions with your team about whether your specific AML falls into that good, intermediate, or adverse risk. I mentioned previously for patients with good or intermediate risk disease that consolidative chemotherapy should be considered. And the standard of care is to receive in the United States, if you receive 3+7 as your induction, you should receive at least what we call intermediate dose cytarabine or IDAC consolidation. There are times that we alter the doses of chemotherapy during consolidation based upon a number of factors. Alternatively, one other induction strategy involves the use of a hypomethylating agent like azacitidine, also known as Vidaza, or decitabine, also known as Dacogen, together with a chemotherapy pill called venetoclax. And for many patients receiving that latter induction, those same medications are used for consolidation. But I promised you previously to talk a few minutes about patients with adverse risk disease and who should be considered for an allogeneic transplant. So allotransplant is not used and not needed for everybody with AML, but it is considered in specific patient circumstances. The patients who should be considered for transplant include patients with higher risk molecular or genetic changes inside of their leukemia cells. When an induction chemotherapy is given and a patient does not respond to their initial therapy and they need a second induction to enter remission, we call that primary refractory leukemia. And patients who might be candidates for a transplant who have primary refractory disease, regardless of their genetic risk, should be considered for a transplant. As mentioned previously, there are a number of blood disorders that can change or evolve or give rise to acute leukemia. And patients who had a pre-existing hematologic neoplasm that secondarily transformed into acute leukemia should be considered for a transplant. Some patients have actually had a different solid organ cancer, like breast cancer, or a different blood disorder like a lymphoma. And the chemotherapy that they received to treat their second cancer may have damaged their bone marrow and given rise to an acute leukemia. Those patients should also be considered for a bone marrow transplant in many circumstances. And then finally, when you meet with a physician and agree upon a course of treatment, and we do recommend consolidative chemotherapy rather than a transplant, there are times that down the road the leukemia comes back. And the goal or objective at that point in time is to retreat the patient if at all possible, knock their disease down again and get them into remission. And at that point, the long-term control of the disease is mainly allowed when one considers a transplant in second remission. So I hope our time today has helped you understand how we establish the diagnosis of acute myeloid leukemia by identifying 20% or more myeloid blasts in either the peripheral blood or bone marrow, and that additional testing at the time of diagnosis using genetic tests are important because we'll use that information in recommending a specific induction or initial therapy, as well as consolidation. I'll admit, in many cases, acute leukemia requires urgent therapy because patients' blood counts are severely low at the time of diagnosis. And a close and accurate discussion with your care team is important to evaluate the patient's clinical case and their fitness for different induction strategies for their leukemia. The goal of induction chemotherapy is to knock the disease down and obtain what we term a remission. But one round of chemotherapy is never enough. What I often say is one and done is not enough, and all patients do need to receive additional therapy for long term disease control. And the choice of that long term therapy or consolidation needs to be personalized. It takes into account the etiology of the leukemia, what potentially caused it, including the genetic changes that we talked about testing for previously, your initial response to induction chemotherapy, and the potential long term outcomes that you're seeking for your care and management. With that, I'll thank everybody sincerely for their time and attention. And as mentioned previously, I'd be happy to take questions to the best of my ability. Thank you again for taking the time this afternoon to listen to me.
Thank you so much for presenting. And we, like he just mentioned, we're going to go ahead and open it up for questions. So if you have any questions, you can either raise your hand and just ask the question verbally. So to do that, you would hit the raise hand button and then unmute when it's your turn. Or if you'd like to type out your questions, you can do that through the chat icon, and then we'll go through and we'll get those questions asked for you. So let's see, while I pull up the chat to see if there are any questions for our presenter today, I would be curious to see, one of the things that can be difficult is figuring out how, as the patient or as the caregiver, how you can work with the care team in order to make some of these decisions about care. So you talked a lot about how the physician is making the decisions based on the genetics and with the diagnosis specifically. How does the patient or the caregiver play a part in that decision-making process throughout someone's time with AML?
Sure, excellent question. I agree that it should be and always should be a two-way street. There's no situation where a provider should enter a room, discuss a diagnosis, explain a treatment strategy, and then walk out the door. I think it's vital that a patient and their family and caregivers and loved ones are actively involved in these discussions. This is not a 10-minute discussion and then proceeding with treatment. I think I've given a few examples of some testing that's performed at the time of a patient's diagnosis. And I think it's important for patients, to the best of their ability, to understand and ensure that that testing was performed, and then to have an open and honest discussion about what are my treatment options. Is there just one option, or are there other options that I should consider? I think it's important to establish the goal of therapy. Is the goal of my therapy to cure my leukemia, or is the goal of my therapy to buy time? And then, vitally important, as was mentioned very, very, very early on by Mary, we obviously are very supportive of clinical trials or clinical investigations to try to move the needle. Acute leukemia is a tough disease. I'm not getting around that. But I think that we have moved the needle. And I think the complexity of the therapy slide that I showed previously demonstrated that there are advancements in the therapy options that patients have. And the only way that we have those new therapy options is because of the graciousness and altruism of patients that have given of their time and abilities to participate in clinical research. So I think it's important for you and your family and loved ones to ask about clinical trial participation. It's not right for everybody. It's not right for everybody, sometimes because of the disease. Sometimes the disease is so well established and the therapy of the disease is still so well established that there really is a quote unquote best therapy option. But there are times that the best therapy option is not known. And at that time, there might be clinical trial options to participate in for patients, and you should understand the risks, the benefits, and always understand that it's your right to participate or not to participate in clinical trials. This is not like buying a house or a car. You're not sold and have to stay with that clinical trial. You always have the right to interrupt participation. Obviously, speaking to your physician about the reason to interrupt your participation in the clinical trial, but it's your right to ask questions at all times and understand where you are in the grander scheme of your chemotherapy and your treatment, to understand your therapy path forward. So an open and honest discussion and taking time. Many times we do say that it's important, if you're confused, have questions, to seek a second opinion. And that's true in acute leukemias. But I will also admit that there are times in acute leukemias where patients present very sick and are hospitalized immediately. And many times between the time of diagnosis of acute leukemia and the initial therapy, it's often as short as 48 to 72 hours because of how sick patients present. And so sometimes, and it's important to ask, do I have time for a second opinion? But if your physician says, I'm concerned about your loved one's health and safety, and there may not be time for participation in a second opinion, then I respect that. But that means after the hospitalization, you may then have a window or an opportunity to seek guidance or counsel from a second group of physicians just to make sure that you're on the right path. But again, always feel comfortable asking questions. If a physician says that they don't have time to discuss your case with you or limits the ability for that interaction, I do think seeking a second opinion is always a wise and important avenue to understanding your treatment and your diagnosis.
Thank you so much for explaining all of that, and especially the clinical trials piece. I think there's a lot of misconception around clinical trials, or it's hard to know what their role could play in treatment. I think there's, one version of clinical trials that you have that you see in the media that talks about, it's the last ditch effort. But especially in diseases like AML, there's so many opportunities for participation in trials at all different stages of care. So I really appreciate you going into that. We have a question in here from Lynn, and she says, I am currently 4 years post stem cell transplant for AML. After the 5 year mark, what is the survival rate estimated to be? And she says there's not a whole lot of conversation around survivability.
Very important question. And first and foremost, thank you for the question. And first and foremost, congratulations on your success. And the reason I word it that way is that individuals who are 4 years out from an allogeneic transplant have admittedly likely a more favorable prognosis. Again, there's some details that I don't absolutely know about your case, so I want to be somewhat cautious in making statements about prognosis. But in general, the type of disease that acute leukemia is, if a patient is 5 years or more out from their final therapy, and in your case, the final therapy was the bone marrow transplant. If a patient makes it 5 years out from their bone marrow transplant, for all intent and purposes, they're cured. The relapse rate after 5 years is a fraction of a percent. Now, it doesn't mean that you don't have ongoing health care objectives that you need to continue following with your care team. Obviously, because of the time limitations here, I didn't have time to talk about the risks and side effects of each individual therapy, including bone marrow transplant. One of the complications of bone marrow transplant can be a process known as graft versus host disease. And some patients with or having undergone a bone marrow transplant still need extensive follow-up to make sure that those complications are well managed. But I would say that an individual who has reached the 4 year mark after definitive therapy at that point has a greater than 95% chance of cure. And there's only a very, very, very small number of patients that will relapse between year 4 and year 5. And again, for the most part, far less than 1% of patients relapse after year 5 after the definitive therapy.
And then we had a comment from Joanne where she is asking for additional resources about genetic mutations that cause AML. So I'd be interested if you have any specific, Dr. Bixby, but also Joanne, I've made a note and I'm going to send you afterwards. We did a series earlier this year where we went over genetic mutations as a baseline. We did a deep dive into them with the doctor, and then we've done a couple of webinars on specific mutations that give some really good information. And then we have a couple of really awesome articles. So I'll send you an email after this with all of those resources. But Dr. Bixby, if there's anything else you'd want to add to that.
No, absolutely. And I appreciate that HealthTree has gone the links that they have to provide patient-centered information regarding what can be a very complex discussion about genetic tests and genetic test results. I think some excellent additional resources are the Leukemia and Lymphoma Society. And I'll admit it gets a little bit into doctor speak, but the National Comprehensive Cancer Network, or NCCN, and so if you go to the website nccn.org, they have some patient specific information regarding each disease that the National Comprehensive Cancer Network discusses care and management of. And that patient specific information in acute myeloid leukemia does talk about what genetic testing that we test for. It breaks down into the different groups, the favorable, intermediate, and adverse risk subtypes. And so I would look to obviously HealthTree, Leukemia and Lymphoma Society, which is lls.org, and the National Comprehensive Cancer Network, or NCCN, at nccn.org.
And Joanne, I'll send links to those two in the email as well. Those are great resources to also get some information. Um, well, thank you so much for your presentation today and for answering our questions and helping make, this diagnosis and genetic parts of AML make a little bit more sense.